Hold on. There you go. Yep.
Okay. All right, can everyone see it?
Not yet.
No.
Oh, okay. Let's see. How about now?
Yes.
Okay. Good afternoon, everyone. My name is Kristen Weston. I'm a Frontier graduate, and I am a nurse practitioner. And today we're going to talk about timely depression, suicide screening, and transition of care in an addiction treatment setting. So my aim statement includes decreasing average days between discharge and timely first psychiatric appointment by 80% by June 21st, 2019. From the St. Lawrence County Health Assessment, the following health problems were identified in areas of concern in this community. Access to health care, 55.3% out of the 797 recipients, and 69.8% out of the 795 recipients felt depression was a problem in their community, and 44.5% out of the 784 recipients felt suicide was a problem. So I did 20 random chart audits were completed, and the results revealed that St. Lawrence Addiction Treatment Center has a 100% non-compliance rate with depression screening and plan of suicide prevention, a 65% non-compliance rate on lack of primary health provider. In 2007 to 2009, 6.6 per 100,000 people committed suicide in St. Lawrence County, and 9,870 people died before the age of 75 from unintentional injury, which is the third leading cause of premature death. This number includes overdoses from alcohol and substances. My long-term goals include improving mortality and morbidity rates from the patients suffering with addiction by improving transition of care follow-up. My short-term goals include how to advance the discharge planning for each patient admitted. So my ramp A, I plan on doing the project briefing tool. My ramp B, I plan on doing the Mayo Clinic decision-making depression medications. Ramp C, the Columbia Suicide Severity Rating Scale, and the PHQ 2 and 9. And my ramp D, the case management log. And my balancing act includes increasing patients' length of stay at the St. Lawrence Addiction Treatment Center. My stakeholders include providers, staff, patients. Other stakeholders include administration and management and Dr. Diane Jowls. My initial change include admission. During the admission process, I will utilize the Columbia Severity Rating Scale and the PHQ 2 and 9. In transition of care, set up patients' appointments prior to discharge, and utilize the Mayo Clinic decision-making tool for depression medications with patients, and utilize the project briefing tool during the QI meetings. Some barriers include lack of motivation of staff for utilization of care, feasibility of process change, resistance to change, non-congruency in staff's attitudes towards project, lack of education on depression medications with the patients, lack of screening tools for depression and suicide, and lack of process to ensure transition of care. And these are my references, and everyone have a great day.
Okay. I'll go next. Is that fine, Kristen?
Yeah, that's fine.
Oops. Can you guys see it?
Not yet.
What did I do wrong then?
Push the green arrow.
I did.
Okay.
Yeah.
And then do the whole screen.
Share all. Yeah.
Yeah.
How about now?
Yes.
Okay. Hello, my name is Tamara Porter, and I will be sharing on improving efficiency and patient-centered care in a surgical dermatology practice. My aim is to improve efficiency and patient-centered care of Medicare patients in a dermatological surgery center by 30% by July of 2019. The references to patient engagement and satisfaction of the Affordable Care Act of 2010 solidified the idea of patient-centered care as a key component of quality healthcare in the United States. 89% of patients stated that they are currently dissatisfied with their organization's use of patient engagement technology. Patients want to take an active role in improving their health and are interested in participating in choices about their healthcare. A study published by the University of California, Davies revealed that a higher amount of patient-centered care results in a significantly decreased annual number of medical visits, less frequent hospitalizations, and fewer diagnostic tests, resulting in significantly reduced medical costs. This demonstrates that patient-centered care and efficiency are necessary in this economy of increased healthcare costs and decreased patient satisfaction. Our patient survey results showed that our patients were very satisfied with their care, but only 33% felt they had the information to make a healthy choice for themselves. This translates into a patient engagement issue, as also evidenced by a gap in patient knowledge about pre-op instructions and post-op care. There's also a lack of efficiency, as 67% of patients polled felt that the wait time was too long before seeing the practitioner. The team survey showed only 44% of staff admitted to allowing time for questions after explaining procedures. This data reveals gaps in patient-centeredness and efficiency. This improvement will benefit the team in that it is designed to improve efficiency and cohesiveness. The patients will be better informed, and patient satisfaction will improve as patient-centeredness improves. More patients will be able to be seen if efficiency is improved, and this will benefit the community. The business impact will be greater revenue and less waste. Implementing these tools will improve team function, which in turn improves patient experience of care. My measures, process, and outcome. For the team, the outcome will be an average score from huddle questions. The patient outcome will be an average score of the tool Your Skin Matters. The compliance outcome will be the number of correct answers on a checkoff form, and the outcome for my RAMP 4 will be an average score of survey questions. My stakeholders are the physician, myself, 4 medical assistants, and 3 office staff. Initial changes for the team will be a kickoff meeting for the first stage, and then we will begin huddles daily. My second ramp will be a Your Skin Matters handout for patient engagement. My third ramp will be to implement staff use of pre- and post-op checklists. And my D ramp will be with perceived wait times. We'll be changing the waiting room, and we'll have a handout of menu of activities, including puzzles, and the Your Skin Matters handout at check-in so patients have something to do while waiting. This is an example of my Your Skin Matters patient engagement tool. And this is the menu for check-in. There are crosswords and word searches that are specific to our office. And then the final page of the advisor. Most of our patients are Medicare patients and older people, and I thought it would be interesting for them to give some advice, etc. Our barriers will be lack of enthusiasm about adding something else to an already busy schedule. Our population are elderly and may have difficulty filling out the handouts, and it may not be enough for the staff to use a pre- and post-op checklist. I might need to implement something that the patients take home and check off as they do the actions. And my D, wait times, possible inconvenience of more tasks for the staff to do. And these are my references. Okay.
I could go next, I guess. Screen share. Can you all see my screen?
Yes.
Yes.
Okay, great. Let me just pull up my time. Okay. Good afternoon, everyone. Let's discuss improving patient care in a myelodysplastic syndrome through the use of standardized patient engagement tools and primary infusion nurse model. This would be the flow of the conversation. Clinically significant depression has been identified in 16 to 22% of all cancer patients, with increased rates in those with high symptom burdens, as seen in patients with myelodysplastic syndrome and acute leukemia. In fact, suicide rates within the first week of being diagnosed is 12 times greater than the general population, illustrating a great need for a patient-centered initiative. The implication to the healthcare system is great, since depressed cancer patients accumulate annual charges 113% higher than non-depressed cancer patients. Our vision would be to provide patient-centered care focusing on the whole patient experience and symptom burden while normalizing and prioritizing distress and depression screening. For the rationale, despite the National Comprehensive Cancer Network recommendation that cancer patients should be screened for distress at every medical visit, a sample of 20 patients from our myelodysplastic syndrome clinic illustrated that distress and depression screening was not being conducted on any of the patients. The patient survey statement, "I am aware of community resources regarding my MDS/leukemia," was only true for 66% of the patients surveyed. Also of note, 0% of the 20 charts audited had a patient that was referred to a support group. In a patient survey, when asked on a Likert scale if it would be nice to track my symptoms and changes in my health as it was happening, the mean response was 92% in favor of this initiative to establish more patient-centered care. When the team was surveyed and asked if the patients would benefit from continuity of nursing staff during their treatment visits, all 6 questioned team members strongly agreed with this statement, in contrast to the current model that does not support continuity of infusion nurses. So for the expected outcomes and benefits, it is common for patients suffering from depression and/or anxiety to not follow through on referrals and/or comply with treatments. Therefore, the implementation of this patient care initiative will improve the patient's compliance with their treatment and appointments, in turn improving their overall disease management. Keeping track of any side effects the patients may have from chemotherapy improves the patient engagement in their disease process, while it also assists the team in managing and tracking their symptoms. Finally, the initiation of a primary nursing model improves communication between the patient and the infusion staff, but also improves the knowledge base and skill set of the infusion nurses. This results in shorter wait times, decreased medical errors, and better communication between the clinical team, infusion nurses, and patients. So the aim is to increase right care management for 75% of the outpatient MDS/leukemia patients by June 21st, 2019. The PDSA test of change includes a B-ramp that has a chemotherapy worksheet that patients will receive when they're getting consecutive chemotherapy, an MDASI screening tool. The D-ramp would include a case management log, and the A-ramp would be a continuity nursing model. And so how do we know that the change is actually an improvement? Distress and depression would be identified in a timely manner, and the team would be able to intervene with right care management, overall improving the patient's outcome and their perception of their health. And of course, this chart is an outline of how I plan to make that happen with the help of my team. So the key stakeholders include the patients, which are by far the most critical aspect to the success of this project, as well as the attendings, clinical RNs, medical assistants, nurse practitioners, social workers, infusion center managers. And so for some of the barriers, for the chemotherapy worksheet, the biggest one is patient compliance, which we will try to overcome by training the infusion nurses to assist the patients with its use and reiterate its benefit to them. For the MDASI screening tool, it can be the patient's personal mental health stigma, and we overcome that by reassuring the patients the screening of the stress and depression is a standardized process. For the case management log, one of the greatest problems is the provider time constraint to fill out the log. And so we would disperse responsibility evenly, and the patients would be completing their forms while waiting to be seen or in the comfort of their own homes, and then bring to their follow-up appointment. And for the continuity nursing model, because there would be a smaller pool of nurses, if there's any unforeseen event or delay in the care, it can increase the patient wait time. And we would combat that by reviewing the patients coming in for treatment ahead of time to assess if there's any anticipated delays and plan accordingly. And here are my references. Thank you.
I can go. Can you see it? How about now?
Yes.
My name is Kelly Elwell, and I am working at Porter Medical Center. My project is patient-centered advanced care planning, healthcare agent delegation, utilizing the Conversation Project in a critical access hospital. My aim statement: increase average right care score at Porter Medical Center 60% by August 2019. A right care is defined as an average score of the following: completion of healthcare agent form on all patients, COLST form if indicated, palliative care referral, hospice referral if indicated, life-limiting illness education handouts given with discussion with the provider. Inevitably, 100% of people will eventually die, and Medicare spends over $170 billion on the last 6 months of life. 1 million patients with life-limiting illnesses die every year without ever receiving end-of-life care services. My chart audit at Porter Medical Center showed a lack of COLST forms on 100% of charts and 80% of them without a healthcare agent delegate. There's significant gaps in advanced care planning for hospitalized patients, including education surrounding their prognosis. The reason for the effort is patient-centered care. The team reported only 11.76% of patients understand their prognosis. So the first step is educating them about their life-limiting illness to allow them to make educated decisions. Audit showed 71.43% of patients wish they have a written information on advanced care planning, and additionally 57% of patients noted that providers did not discuss advanced care planning or healthcare agent delegations. And providers noted that a lack of standardized screening process for palliative care. 35.29% of team members felt that there was unclear roles or contributing as a barrier. My expected outcomes for the team, organization, patients, and community include increasing awareness of advanced care planning, available resources, educating on life-limiting illness and prognosis, exploring goals of care with quality of life in mind, and decrease the burden of healthcare interventions for patients that wish to have palliative or hospice care. The business impact includes increasing quality of care as a patient-focused. This equals increased patient satisfaction. Decrease unnecessary transfers to higher levels of care, since we are a critical access hospital. Decrease interventions that do not contribute to improved quality of life, and decrease healthcare costs, especially at the end of life. New tools will include the point of care team checklist, huddle checklist, healthcare agent delegation form with a COLST form, case management log, in addition to providing life-limiting illness education handouts on admission, and new process of utilizing the surprise question. My measures worksheet shows a teamwork ramp A, utilizing the surprise question: would you be surprised if the patient died in the next 12 months? My goal is to have 60% of patients admitted to be screened, and if they answer no to, if the provider answers no to that, then they would have a palliative care referral. My patient engagement includes utilizing the Conversation Project, worksheets pages 2 and then 4 through 6, and life-limiting disease handouts that would be patient-specific. And my goal is 60% of patients receive the Conversation Project packet with instructions and meaningful discussion with the provider regarding where I stand scales. Ramp C includes a provider checklist or a point of care checklist that makes sure that the surprise question, the COLST, the healthcare agent, palliative care referral, provider documentation of who the discussion took place with, and the hospice admission, if needed, is taken care of. And I am aiming for an average right care score of 60%. And finally, the case management logs, closing the gap in care, an average right care score of 60%. My goal for the balancing measure is to not have greater than 56 hours per week. Key stakeholders include patients, families, hospitalists, palliative care providers, and nurses. My initial changes that I'm going to encourage the staff to complete the Conversation Project for themselves. Patients are going to be given a COLST form for review. C, they're going to be palliative care weekly meetings. And D, chart audits to make sure that the right care components are there. Barriers or time constraints, as always, increased responsibilities of providers and nurses, lack of patient and family engagement, and lack of support from providers and team members. And here are my references.
Good job. I think that leaves me.
Yes, you're next. You're last.
we go. Whoop. Okay, can you guys see?
Yes.
Okay, great. I had a little bit of a delay there. I'm not sure what that was about, but I would like to invite you guys to join me, Sandra Scott Watson, in improving cardiovascular outcomes for hemodialysis patients at North Tulsa Fresenius Clinic. The aim of this project is to increase comprehensive bone mineral care to more than 90% using KDIGO guidelines, a checklist, and a care coordination log within 90 days for all of the dialysis patients at the clinic. End-stage renal disease affects many people. It's increasing every year. The cost of dialysis is enormous. The number one thing that kills dialysis patients is cardiovascular disease, including heart attacks and strokes, just like the rest of the population. What's different about dialysis patients? A chart audit revealed that many of our patients have phosphorus and calcium minerals out of whack and are out of normal range. This causes their PTH to get out of range. And overall, 46% of our patients had all three of those lab indicators within the normal range. KDIGO guidelines recommend looking at a trend of all of those lab indicators. January, our clinic dropped to 40%, as compared to a national average of 60% of patients have all of those labs within the normal range. So patients that have those labs out of range are much more likely to get arterial calcifications. And so they are extremely at risk for blood vessel issues, in addition to what the normal population has with plaque buildup. So calciphylaxis is also something that can happen as a result of these minerals being in excess in the blood. So the expected outcomes is to improve the care for 90% of the patients in the clinic. And really, we want all of the patients to receive education based on the goals that they've determined. And if they need to see the dietitian or the social worker, that gets done, and we follow up on that. If they need repeat labs, that should also be done. And long term, we expect that the percentage of our patients that have those labs within the normal range increases. So for RAMP A, I have a care coordination huddle checklist. And so we can look at the number of staff that have participated with that versus the number of staff that are there. And RAMP B, a patient education tool. So the number of patients that the tool was used on versus the number of patients that were there, so that ultimately the percentage of people receiving education and being engaged in their process improves. RAMP C is a point of care checklist, and we can look at the number of patients that have been seen for the day versus the number of patients the checklist was used on. So that overall the percentage of patients having that checklist used in their care has increased. And RAMP D is a referral care coordination log. So we can look at the number of patients that are seen monthly versus the number of patients that have been tracked on the log. So that overall, the patients that have received teaching, used the care checklist, had labs, and had referrals, and those referrals ultimately have been completed, improves. There are many people that will be affected by this project. All of the patients potentially on first, second, and third shifts at the clinic, as well as the providers, various staff, and the scheduler, many people will be affected. So the proposed core interventions A care coordination huddle sheet for Ramp A. Ramp B is a teaching tool where the patient determines their goals and decides what they want to be taught on. And Ramp C is a point of care checklist. And Ramp D is a referral care coordination log. And all of those ramps will produce a takeaway item that the clinic can continue to use after the project. Proposed barriers, engaging the team in this process may be a challenge. Engaging patients and improving adherence and overcoming compliance will also be a struggle. There are many different providers. Not everyone knows the policies and procedures, and there are many different treatment options. So overall, we've got a plan for those things, and I'm confident that we can do it. So here are the references. Thank you.
All right, so everybody is done and did an excellent job. So out of our group, anyone can answer who told the most compelling story to support their problem.
I think personally, Kathia's, I mean, everybody did great, but just the fact that the suicide rate is 12 times greater after being diagnosed, to me, those are significant numbers, especially after the first week. I mean, are they already sick and having symptoms, Kathia, or is that just the diagnosis that makes them scared?
There wasn't specific data regarding whether the patients already were having symptoms or not, because a lot of our patients, well, actually, you know what? No, I shouldn't say that. The majority of the patients who eventually come to getting their diagnosis, the vast majority of them have some form of symptoms. However, we've had some spontaneous diagnoses, like they'll go in for a pre-op checklist for surgery, and then they have to get their blood counts checked. They get it done. It's abnormal. Then they go and get a biopsy, and all of a sudden they're told they have leukemia. And so you can imagine that for someone who goes through their day-to-day life, feeling relatively normal, maybe a little bit more tired than usual, and then to get a diagnosis like that and then being told that, well, your prognosis is poor, this is a serious disease. And then if they don't have a proper support system, which a lot of the times they don't have, it can be devastating for them psychologically.
Right, and nobody's babysitting that psychological impact, apparently.
Yes, and that's the hard thing with this disease, is that a lot of the primary care providers are uncomfortable with managing these patients because they're so ill, and a lot of them are very critical. And so in our clinic, and in many clinics alike, you have to be the primary as well as their specialist. And unfortunately, when you have to go through all of their physical symptoms, there's very little time to be able to then attend to their psychological needs, as well as the fact that the diseases that we're managing, like I work in myelodysplastic syndrome, which is not a very common disease, because we're getting patients that are coming in from all over the place to be seen. You're having to pile in patients that theoretically for a time slot should only be say 15 patients, and you're seeing 25. And so there really is difficult to find time to manage, their mental health.
Anyone else have any input? So whose PowerPoint had really stood out to you and why? So I'll go first. I really liked, I liked everybody's, but Tamara, I liked how she had the design layouts and all the bullet points and all the graphics.
I agree. I think I have written that down as a note as well. I like the PowerPoint designs, kind of the pictures on her expected outcomes and core interventions. And Kathia, I like that you used on the AIM slide, that bullseye, because
I like that. It's cool.
It really sends that home.
Right. I thought that was interesting. I had that too.
Thank you. Yeah, I did put Tamara as well because I liked how easy it was, simple but effective. So a lot of those bullets really drove home everything. The slides weren't too crowded with information. It was very effective.
Where did you get that PDSA ramp pick, Kathia? Did you make that up?
I created it.
Oh, that was awesome.
I
want to steal that one.
Thank you.
Kelly, do you have anything?
I definitely like Tamara's. I like the way that she used her graphics for sure. But I also love Sandra's pictures because
I know, right? Yeah, that was cool.
I almost left that out, and then I thought, I think they liked it. She said she liked it. I think I'm going to throw it back in there. So I was hoping that it didn't, that it kind of went with it.
Yeah, it really shows like the long-term effect of it if it's not managed.
Creates a sense of urgency for sure.
Right.
Yeah.
So who's or anyone format helped you to understand the data and why?
Again, I think Tamara's the way she laid that out.
Right, and I also like Kathia's like Sandra said, the bullseye that really helped too. Mm-hmm. And I liked how Sandra had the barrier. She had like the caution sign. Mm-hmm.
I wish we could have them up because I can't remember every.
And that's what I was thinking. I was trying to remember. I think that probably one of the most difficult parts is when you get to the operational definitions and like how you're going to measure stuff. I mean, there's just no good way. I mean, it's just very wordy and right. That's a tough one.
If I may, could each of us, because like you said, it's a little difficult to be able to fully grasp because 5 minutes is such a short period of time to really be able to just explain your project. If we all can just say succinctly from this flow to this point, how do you expect your project to flow? And how does one link go to the other and so forth? Like, I guess, so to make sense, I'll try to explain mine. So from the beginning, we're having patients who are coming in for their chemotherapy for their chemotherapy, right? And they have, in this case, we're doing it on patients that are coming in consecutively for 5 or 7 days in a row. And so in this time frame, they're seeing totally different nurses every single day. So there's that lack of continuity. So they would get this, one of the things is they would be getting a chemotherapy worksheet that has their fatigue. Is it mild? Is it moderate? Is it severe? And so forth. And so they fill this out. And then there's a portion at the bottom where there's a comments where when we see them for their follow-up that next week, we're then able to give, we'll look over the sheet, see that this particular thing is bothering them. It's getting worse. Or based on the things that they're checking off, it's prompting me to believe that their stress is very high and their emotional distress is very high. And so then we then go and give them the MDA-ASI screening tool. So that's a prompt for the MDA-ASI screening tool, as well as initial visit, change in their prognosis or relapse in their disease that prompts us to use it. And then, of course, we're going to be managing it through the case log and then creating a continuity nursing model where we're using the nurses we already have, but assigning them specifically to this team. So it might be 6 nurses now that if you're going to see a different nurse, you're going to see a different nurse in that same team that knows the disease, that gets to know you, and they can help the patients fill out these forms and so forth, right? So I don't know if that helped you guys see the flow a bit, but I just feel like I want to hear, if you guys don't mind, to just help me understand the flow, because it was too hard for me to keep track of that.
Right.
I agree.
I can go first.
On yours, just real quick on yours, Kathia, though, can you make it so that they actually see the same practitioner over those 5 or 7 days? Because if it's a different person seeing them, how do you gauge whether they really are, in a crisis as far as depression wise, or do they have a suicidal ideation? If you don't know them, some people you might not be able to gauge.
Absolutely. So that is the goal. And so when I spoke to the charge nurse, who would be the one assigning the nurses with the patients, theoretically, if we can accomplish that, the scoring system that I will use is if we have the same MDS team and then it's the same nurse, then they get more points for that. And then if it's, say, the team, but a different nurse in that team, then they'll get 1 point rather than 2. And so that's one way of tracking it. So our goal is to maintain that, but it's not always feasible because there's going to be days off, or vacations. But I just feel like it's really important, even if they're seeing the same faces and they are aware that they're a part of our team and communicating with the clinical team, then there's more of a trust relationship that's there. So
right, because we do connect with our patients.
Absolutely.
So that's hard to do when they see 7 different people on 7 different days.
Right, and they see them more than they will see us. Theoretically, that's the goal, is that they're going to see the same infusion nurses regularly. They might see us on a weekly basis or, sometimes more frequent, but they're going to see that infusion nurse maybe 7 days in a row. So that's theoretically the goal.
I worked in infusion for a long time, and that was always a huge concern. And, depending on what your hours of your infusion center are, I worked in a 12-hour infusion center so they could do BID antibiotics and stuff. You can't get nurses to work 7 days a week, obviously. Yeah. So that became, but it sounds like you work in a clinic that has limited hours, shorter hours, so you probably have 5 or 7 days.
Well, actually, it varies. There's some nurses that are 312s and others that are 410s. So there's some flexibility there, and there's very few, like the nurses who've been grandfathered into their schedules, that would have set 5 days a week.
Yeah, and it's amazing the amount of peace of mind that gives patients. If it just was so different. Absolutely. So different when they had the same nurse. It was great.
Right.
Yeah, that's the goal.
And I'll explain kind of my project. So I work in a critical access hospital. We have 25 beds, and we have one hospitalist, MD, and myself. And, so we could have, if we split the crew, then there's, 10 to 12, 14 patients a piece, depending. We can have holds in the ER. And nothing was really being done with healthcare planning and advanced care planning. There was times when we had patients that we'd ask, "Oh, are you a DNR or a full code?" And patients don't really understand. Like, "Oh, I want to pump a CPR," and but don't intubate me. They don't understand. So we were ending up with a la carte, basically, of yes, I want this, and no, I don't want that, and it doesn't work like that. So I am going to hope that all of the providers will use the surprise question, which is really simple to use, and you can just do it in your head real quick. Are you surprised? Would you be surprised if this patient died in the next 12 months? And if the answer is no, then they automatically should have a sit-down conversation about DNR, DNI, or what their goals of care are, and what their wishes are. But in addition to that, they really need to understand, and the first thing would be the prognosis. Because a lot of patients in our hospital don't understand that they're that sick. Mm-hmm. So the next step would be to track that using the point of care tool. Our hospital does not allow DNR bracelets or signage in the room, and I've noticed that is becoming a huge issue. It's not a state law, it's an organizational law, but we're part of an umbrella system, so there's a large academic facility in the state that now owns all of the critical access hospitals, and they don't use bracelets, so they're not allowing us to use them. But we had an issue recently where a patient was a DNR. It was tucked in the chart somewhere. He went down. There was no primary nurse there. She was at lunch. The primary provider was not there either. The ER doc came up and then initiated CPR, and the guy was a DNR. And what do you do, right? If you don't see a bracelet or you don't see signage, then of course you're going to initiate CPR because that's what you do. So you can't really fault the ER doc for that, but it is what it is. So I'm finding that that's going to be an uphill battle, and I don't think that I'm going to. So I'm trying to get creative. They won't even allow bracelets that are just colored, like a purple one or a black one or whatever, even without any words on it. which it just blows my mind.
Right, it's hard.
Yeah, so I might have to take that piece out of my project. I'm still fighting that right now, but we'll see. And then just keeping the case management logs of, was everything done? The healthcare agent delegation, the COLST if they needed it, the referrals, and that is my C ramp. And then D is making sure that we're connecting with the primary care provider, because a lot of patients get converted to DNR, DNI, or hospice, and that's put in a note, but it's never really conveyed to the primary care, and I think that's super important. So that's kind of how I see the project flowing.
So how do you assure that, I guess, there's that communication with the primary doctor?
As of right now, they just get the discharge summary, but we're not filling out the COLST forms, which is our version of a DNR that's recognized by the state. So the patient, if they go home and something happens and they don't want to be, they're found down and don't want to be resuscitated, then there's no documentation of that. So we need to make sure that that's, and our hospital itself has 3 different EMRs, one for the ER, one for the outpatient clinics, and one for the hospitalist side. And then the outpatient PCPs have a whole nother EMR. So in the next year or so, we're transitioning to Epic. So I can't really touch anything because they are not, IT is not a changes when we're transitioning to a whole new section. So I'm not really touching that yet, other than encouraging the providers to pick up the phone and say, hey, I transitioned your patient to DNR, and I think that you should have a conversation, kind of thing, because I think the PCP knows them better than we do, and why are we not talking to them about that? It just goes wrong, and that might encourage the PCPs, because a lot of the hospitals are saying, well, that's the PCP's job. Well, not really. They're coming to you on their deathbed, and it ends up being whoever's problem that you're dealing with it. And at the end of the day, it's better to be an ongoing conversation with the patient, not a split decision at when they're right at the end. It should be something that's dealt with by many providers that have an insight on the patient.
So who thinks somebody's presentation engaged the audience the best, and then what specifically did they do to help really bring it home, engaging the audience?
Well, I felt like I was engaged by all of them. I mean,
they're
all fascinating, and
yeah, I think it's so interesting to see everyone's like totally different project, but even though like Thea and I are totally different projects, we still have that we're not screening for suicide or depression. I think that's so interesting, even though our projects are so different.
I mean, I think it was really shocking when you said 100% non-compliance with depression and suicide prevention, given the area that you work in as well.
Right.
Yeah, that seems like a no-brainer, right?
Right. And I think some of the problem is because we don't have a psych nurse practitioner or a psychiatrist on hand, on staff. So, I mean, there's very limited as a nurse practitioner or the DO that I work with can do. So I think we kind of like, per se, like shoo it under the rug, because if we don't ask, then we kind of assume that they don't have a problem. And we don't really have to fix it.
Interesting, really. I mean, about all of our projects, it seems like a lot of it is stuff we know we should be doing. It's just, how do you get it done? And that's implementing the project. I mean, a lot of the issues at my clinic, I mean, like, we know what the barriers are. We just don't necessarily know how to fix them. Time to deal with it on such a small scale, So I think that that's kind of exciting that, when we implement some of these things, we can change and affect their care.
Right. Yeah. And hopefully they continue, if we, hopefully the project site sees it as a good and help make it even more and keep it there in the site. Anyone else? What health disparities were included in the operational definition included? Did anyone have any health disparities that they listed in their operational definition?
Well, I wouldn't say mine was really a health disparity, but they're all older people. They're Medicaid. He only takes Medicare. So if you want to see him, you got to pay for it. Pay at time of service, PATOS.
Oh.
So we only have, mostly our patients are 65 and older. So, you know, they have their own difficulties.
Right.
So age, I guess, disparity, but.
And I don't specifically have like minorities or ethnicity named in mine, but I mean, my patient population is definitely affected by poverty and a lack of resources. And then, you know, I see a large percentage of Native American and, you know, Hispanic and African American patients. I mean, like, so that's kind of, I have lots of different things to think about. So I think it's important in planning to think about what the issues are in populations, but I didn't want to separate out just one population because all of those make up my unique population.
Right. Mine's kind of like a lot of them, because they have legal issues, don't have a license, but we want them to get proper transition of care and making sure they're going to psychiatric appointments and making sure they're going to primary care. But we live in such a rural area, there's not public transportation other than taxis, but of course, you know, that costs so much per mile. And so it could be, you know, 20, 30 minutes to the nearest primary care provider. So it's really lack of transportation is some of the issue to get our patients to where they need to go to get them to their appointments.
Yeah. I think for my population of patients, it's the lack of knowledge about the disease. Like there's not a lot of people that understand what or know what myelodysplastic syndrome is. So the patients can be not worked up quickly enough or not come to us in a timely manner. And then even when they come to us, there's just a lack of knowledge on all of our patients, regardless of their age or their educational background. There's just a total misunderstanding. And so they go to Google and they really have no idea. And then they're telling me, so you're telling me I'm going to die, right? That's it. Like this is it. I might as well just prepare for it. And so, yeah, I would say that's definitely our biggest problem.
Dr. Google, right?
Yes.
Yeah, that's what's. Does anyone have anything else to add? We're getting ready to wrap up.
I thought that surprise question thing that Kelly was saying, I've never heard of that before.
Right, I mean,
but
yeah.
That makes a lot of sense. Would it surprise you if this patient died in the next 12 months? And if you say no, then you need to be thinking that they're going to be dying within the next 12 months. So what do we do to help them prepare for that eventuality?
It's so funny because I'll go down to the ER to admit somebody and I'll be like, wow, I'm surprised that they're still kicking, or hey, you know, because we see a lot of the same people. But it never crossed my mind that that was something that you could use as a tool.
Right.
And I stumble upon it, and I'm like, how simple is that? I mean, because I work
Right.
with a lot of physicians that are very old school and they aren't about to change their ways
Right.
at all.
That's the way it always was.
Right. And so this is something that we can, you know, if they don't do it at admission, then we'll do it at huddle. And, you know, it should ideally be done on admission, but I'm kind of giving them a little bit of slack there in allowing us to do it at our daily huddle meeting and just squeezing that in because we're talking about each and every patient anyway. You
Right.
know, be like, hey, do you think we're going to have issues in the next 12 months? You know, and it seems like if we had more resources, just about every one of our patients, unless they're there for something simple like an appy or, you know, cholecystitis or something, but most of them have life-limiting illness, and most all of them should have a palliative care consult.
Yeah, absolutely. I had a quick question, Tamara, regarding the word search. When you're handing it out to say patients, but then they're coming back more frequently than the 8-week time frame, do they get the same puzzle again, or?
Well, I got to come up with some.
Okay.
I have to come up with multiple, yes. Because of our demographics, they do things like that, you know. And
Mhm.
I mean, we had patients, they waited on their surgery for 2 hours.
Mm.
Personally, I'd have been gone. I'm like, you can fix it next week, or, you know, fit me in somewhere else. I'm not waiting. So if we can decrease their perceived wait time, they'll be happier. So crossword puzzles, word searches. I found a website that you could just put the questions in and they actually make it for you.
Oh, that's cool.
Yeah. And then I'm thinking, well, I wish we had newspapers, because then I could just print, you know, one out of the newspaper. But this doctor likes to bring his golden retriever, so everybody loves the dog. His name is Bones because it's Dr. McCoy from Star Trek. So everybody asks about Bones. So Bones is in the word search or crossword, and you know, just some things that are specific to our site. So
That's nice.
we'll see how it works, because there are magazines. He doesn't have a TV in there. He said because there were, even when you do the paid things, there's too many advertisements that he says he doesn't, you know, he doesn't want them necessarily to go out and use that particular cream or lotion or whatever. So he got rid of the TV. He doesn't like the ads. He's very specific. But most of his patients have been with him for 25, 30 years. So
wow.
it's really hard for me to elbow in. I get the younger ones because they haven't been there as long. But I mean, we have 97, I think, is the oldest I've seen so far. But he has them up in the hundreds that he's still. Because, I mean, skin cancer is based on time in the sun and time being alive. And, you know, some of them he'll say they've outlived their skin.
Mm.
And we're just treating the worst of their skin cancers, but they have multiple skin cancers.
Right.
So, yeah, I'm just going to figure out ways to keep them busy for a little bit.
Right. All right. Anyone else have any last minute comments?
Oh, I didn't want anyone to think, by the way, that I wasn't listening to their project when I asked for everyone to like explain it. I just want to put that disclaimer out there. I just wanted to understand the flow a little bit better, because I just
right. It's yeah, you're right. Yeah, it's hard to get the flow in 5 minutes.
Right.
Yeah.
Right.
The problem
I
with
think
mine is it's not clinical. It's going to be workflow, because my physician he's so anal that he doesn't do anything wrong. I mean, I couldn't find any true gaps other than, you know, patient satisfaction in the sense of waiting too long, and maybe the education isn't quite as, but there again, most of them say, well, I trust him. Well, I'll do whatever he says.
Right.
So it really was a hard place to find gaps that could be corrected.
No, but I think you did a good job.
Right. I just have one more question for Tamara. Are you going to send us the link of the video at the end?
I am. I will email it to everybody as soon as I stop the broadcast.
And then I'll email everyone their times too.
All right, perfect.
Everyone was under 5, so don't even worry.
Hey, just a great big thank you to you guys that all had a administrative part. I feel like I got the lighter load, and boy, I'm relieved. But I think you guys did a great job, and thanks for doing the extra work to help get our team through there. So kind of along with the announcement they sent out on Canvas this week, you know, like teamwork, I think it helps to have this smaller group, and thanks everybody for doing everything.
And Kristen, you did a great job facilitating, so thank you.
Yeah.
Oh, thanks. Thanks. All right. Any last minute questions? If not, we'll have Tamara stop the recording.
All righty.